Good afternoon and welcome to today's Education Grand Round session. We are honored to have Dr. Joe Shapiro present on peer support, the key to sustaining our well-being. We often hear of the importance of well-being for the healthcare provider. As health professions educators, you are not only responsible for caring for yourselves and patients, but also for role modeling well-being for your learners. Over the next hour, Dr. Shapiro will talk about the barriers and consequences to health profession educators not receiving the necessary emotional support and highlight the key principles to peer support programs that can be designed to overcome these barriers. And now to share a little bit about our presenter before we get started, Dr. Joe Shapiro is an associate professor of otolaryngology, head and neck surgery at Harvard Medical School. She is principal faculty for the Center for Medical Simulation in Boston and a consultant for the Massachusetts General Hospital Department of Surgery. In 2008, she founded the Brigham and Women's Hospital Center for Professionalism and Peer Support, where she served as the director for over 10 years. In 2018, Harvard Medical School gave her the Shirley Driscoll Dean's Award for the advancement of women's careers, and she continues to educate and assist organizations in developing specific programmatic and educational approaches such as peer support, disclosure and apology, well-being programs, professionalism initiatives, and conflict management. And finally, before I hand things over to Dr. Shapiro, I want to thank her for spending her time with us today. And she also wanted us to let you know that you should feel free to post questions or comments in the chat as we go, or unmute and ask your questions. She encourages your interaction. So now, without further delay, please feel free to get started when you are ready, Dr. Shapiro.
Wonderful. All right. It's such a pleasure to be here. I'm just going to make sure that you could see my slides. So let's make sure. Does that work? Yeah. Okay, good. Thank you. Such a pleasure. I am an educator, a clinician educator, and I just really enjoy talking to people who care about teaching and learning, especially within within the healthcare profession. So thank you for being here. And I want to thank all your leaders who are obviously incredibly dedicated and wise and care very much about you all. And also I want to honor the fact that you all showed up. It's a lot. I mean, to take an hour out of your day. I know you have other things you could be doing. And I think it just says a lot about you that you decided to take some time for your own professional development. And that's a beautiful thing. I think it's fun to learn, but sometimes it's hard to take time out to do so. So thank you for that. I'm actually going to talk a bit about culture because I think it matters really intensely in what we're going to talk about. And when I talk about culture of medicine, I'm talking about, not at your organization or mine or one state in the US or even our country alone. I'm talking about the culture of medicine in general. And what I found, and I have great respect for, I love cultural differences, and there are many, and I've had the opportunity to work abroad and all over the US, and I'm so respectful of differences. What always surprises me also, though, is how consistent the culture of medicine is across all the organizations I've ever had the pleasure of working with. And we have some parts of our culture that are beautiful, like just to put one out there, that we're all healers in some way, right? And that's never going away. We're always going to be oriented to healing. I do think if we're going to get better and be better, that we're going to have to look at the kind of the dark side of our culture. And this is the one I want to talk about, which is that for many years, I think our systems have treated us as inexhaustible resources, ignoring our physical, mental, and emotional health. And I also think that we've internalized this, and I think to our detriment. So I want to talk a little bit about that, because what we're going to talk about today is really in trying to change this part of our culture. So I'm going to focus on one of the absolute hardest things that any of us has to confront. And if you haven't yet, you will. And if you haven't yet, you'll also probably worry about it. I will focus on, when I talk about peer support, I'm going to focus on peer supporting a colleague who's been involved in an error. But there's, so that's what I want to say, that I always like to teach to the hardest thing, and that's the hardest thing to support for. But if you can support for that, you can support for anything. But I just wanted you to, individually reflect on thinking of a particular event or circumstance in your professional life. And without saying what it is, just because what's most important is really to kind of put out there what's an emotion that you remember feeling at that stressful time. And what I want to say is I'm going to ask you to put it in the chat. I can guarantee you that nothing you say will be unique to you, in the sense that these emotions tend to be really very constant to the kinds of challenges that we meet in our profession. So just, what kind of emotions do you remember feeling? And you can say what happened to, what the event was, or you don't have to, but yeah, just welcome in the chat. Thank you. Sadness, grief, loss, embarrassment, for sure. Yeah, really, these are pretty tense. Yeah. And maybe even fear, like, oh gosh, what's going to happen? This, especially if we're talking about any adverse event or bad outcome. Dread. Yeah, what's going to happen next? Wanting to run away, feeling incapable, questioning our own competence. Anger, fear, why me? For sure. Again, depending on the event. Guilt, for sure. Okay, so thank you for answering that. And I really will tell you that none of us is unique in this. And I think knowing these are shared emotions is really helpful. So when we talk about peer support, I want you to have the idea that peer support can be supporting a colleague in any of these stressors, like an adverse event. Sometimes adverse events are due to errors, so those as well. Communications with patients after adverse events, how to help with disclosure and apology. Just emotionally stressful patient outcomes, things we see that are just devastating, that have nothing to do with our care, but just the circumstances of a patient's life. Being named in a lawsuit, some chronic stressors, certainly COVID was a huge one, being bullied at work, patient complaints being reported to the board, to the National Practitioner Database or the board. And then, if you've read any literature on this, that the incidence of patient aggression to healthcare providers is increasing. So any of those moments are really highly stressful. So this is sort of broad in terms of what we can do peer support for. So you already really answered this, which is focusing on an error. I think some of the emotions that we all tend to have. And I want to delve in, as I said, to use this as an example of where I think these stressors really come into play and what we can do about them. So what I'm going to talk about are the very common emotions that people feel in the particular stressor of having made an error. And that said, we know a lot about that, but what anyone feels individually at that point is them. I mean, we can't say, oh, I know you're going to feel shame, or I know you'll feel tension, or what have you. But we will, sorry. So it's very individual what people feel. And yet there are some very common and known reactions. And that's what I want to go through with you. So people feel sad, as was mentioned in the chat. Shame. Shame goes from where you are saying, I feel really bad about this and sad about it. And then you add on, and it happened because I'm not good enough. I'm not a good enough physician, pharmacist, nurse, whatever. It can trigger self-doubt and imposter syndrome. And it's pretty powerfully negative feeling that shame is. So I was always wondering, like, why are we so ashamed? And I really thought this study helped me see this pretty clearly. And it was where they looked at the similarities between aviation and medicine when it came to errors. And sorry. And they found that both stress the need for perfection and a deep perception of personal invulnerability. So I'm gonna translate this because I think it's very real to most of us. We have been taught, and we're taught for forever, that the way to keep patients free from harm is to expect error-free performance from ourselves and each other all the time, right? Which would be great. I mean, we all want zero harm. And the thought was, to get there, you just have to not make any errors. There's a big problem with this, and that's an impossibility. Humans are humans. We make errors actually at predictable rates. You can't change outcomes by preventing all errors, by requiring 0 errors. There are many ways that we could and should and do prevent harm to patients, but it will never be by eliminating human error, because we're wired to make errors. And yet, do we really internalize that? I think we don't, and we think actually we still should be error-free. Now, the way we should be working, instead of saying nobody should ever make an error, would be, okay, let's each personally decrease the chance of our making errors. It won't be 0, but we can decrease it by being well rested, getting help when we need it, practicing what we need to practice, reading what we need to read, all those things really important, and our obligation to do. In addition, we should have a system that's set up to prevent what naturally any errors might happen just because of chance, from reaching the patient. And the third very important thing is we should actually look at the system and take out or change the ways that the system makes us, puts us at higher risk for making individual human error, like asking us to see too many patients or cover too many patients, those as an example, or not giving us time to sleep and recover. Those are systems issues that set us up to make more errors. So those are all the things that need to be dealt with, personal and systems. But that's very different from what I think we feel like, which is this, as it says in the study, this perception of that the need for perfection. Okay. So, I'd like to ask you a rhetorical question, which when I talk to, a big auditorium full of people, I just go, could you please raise your hand if you've never doubted yourself, which was this slide here. And of course, nobody raises their hand, because I don't care how smart and wise and experienced you are. We all have moments of self-doubt, and they often come into play after we have made an error, for example. And I just want to say that I think that's healthy to a degree, that we think, oh gosh, should I be doing this, at this work? But then I think we need to put it in perspective, saying, we're human and we do make errors. So I think also society set us up for this false expectation in some ways, like this whole healthcare hero thing, which sounds really good. And I think it comes from a beautiful place. It's a double-edged sword. It feels good to hear, but also I think it sets us up to feel like, somehow heroes with our capes, don't need the same amount of sleep, are capable of just, like during COVID, of just doing, being assigned to a different place, even if you didn't know what you're doing, and, just seeing a whole lot of death without, it affecting us. And that's just wrong, because we are human. We're not caped heroes. And so I think we just have to be careful about societal expectations. And another example of that is there's a children's hospital where their sort of tagline on their vans, like their banners outside and inside their hospital, says, "Until every child is well." Okay, now that's crazy, because every child entering a children's hospital is not going to be well. That's an unreasonable expectation to say that we can meet that expectation. So I think some of this does come from external that we then internalize. I think also the culture of medicine, we place a high value in getting, putting our head down, getting our work done, just do your job. It's not supposed to hurt, walk it off. We can usually fix things. And these are times when we may not be able to. Fear, somebody mentioned something close to fear. What are we afraid of? Anybody, can you put in the chat? Like, what are we afraid of after an error? What are the kinds of things that might go through our mind? Oh gosh, I am worried about. Anybody? Or you can come off mic too, off mute too, or the chat. What are we afraid of? Yep, repercussions to us, to the patient, not meeting the standard of care, maybe we'll harm somebody else, people questioning our abilities. Absolutely, these are all fears. Anything, losing our license, so some kind of negative job consequence. What else are we afraid of after errors? Like, it's kind of the elephant in the room, but I think everybody worries about. Anything you can think of? Sued? Yep, absolutely. Not unrealistic as a fear anyway. All these things can swirl through our minds, and I want to unpack one of them in particular, and that is this idea and people, sorry, I want to unpack it in the sense that we're afraid of all of these things, and then somewhat kind of frustrated and angry that we are being subject to a certain kind of reaction that doesn't seem consistent with what we're supposed to be doing. So what do I mean by that? Did you all at your organization, did you get the memo that your whole organization is done with shame and blame? No, right? No organization anywhere sent out a memo saying, okay, you're done, you're fine, you're good. It's absolutely something that we want to move on from. Shame and blame actually makes the system less safe, but we've been doing it forever. And so we want to shift to a safety culture, which is where we do have personal accountability and systems accountability, as I mentioned earlier, with the eye of not shaming and blaming, because that makes the system less safe, with the goal of learning so that we don't do this again to any other patient. But you can't just go from decades and decades of shame and blame to another, to a different culture by just telling people that we are. So I want to sort of show you a way to think that how we still are in the shame and blame. This was a really interesting study where they looked at the referrals to women surgeons after they'd had a patient death, and the referrals dropped by 54%. Where if a male surgeon had a patient death, they really didn't have much effect. It didn't have much effect on their referrals. This is obviously unconscious bias, and that's, I think, what the point of the study was, to see if that was true. But I put it up here just to say that it's just a specific example of where we do judge each other. And the person in the chat who said we're kind of worried about what others think of us, or our colleagues, or repercussions, but that's real, because we tend to judge. In this case, it happens to be skewed against women, but I think generally it's not. We judge each other, and the only way to move beyond that is to recognize that we're being judgy and say, oh, you know what? I think, this person's really smart and committed. I wonder what did happen. Maybe there wasn't even an error. And if there was, it was probably a reasonable choice at that moment. So, but this is why I put this up to say it's valid to worry about what we think of each other. And then I put this here to say, look, anytime there is a adverse event, with a significantly bad outcome, many of these processes, depending on where you live, will come into place, like M&M, root cause analysis. The Department of Public Health sometimes comes in to investigate, or the Board of Registration. In the Netherlands, where I've worked a lot around these issues, is the Inspectorate. In the UK, it's the Royal College. We've got the Court of Law. There's also the media. These are things that are triggered often when there's a bad outcome. So I think you could see that these could be done in a safety culture fashion, where we're trying to learn, but often they're not. Often they're done in a shame and blame way. And what I want us to be empowered to do is to say, well, we're going to change, not that we're going to not do these processes, but we're going to change how we do them, right? We have some effect on how is M&M conducted, especially as educators. And can say, like, this is not, we got to make this an educational opportunity, not a shame and blame opportunity. And same thing with, the people who do these investigations. And I would say even the Court of Law is shame and blame for sure. They're not interested in learning when you're in the court system in the US. They're interested in finding who's at fault, usually one provider, maybe several, and then punishing them. So there is an alternative, and it's well researched, and it's been done lots of places. I hope you all are either doing it or thinking about doing it, which is developing a communication resolution program where we're very transparent, which we should have been anyway, with patients about what happened. And then if the care is unreasonable, that is outside of the standard of care, then offering financial and non-financial restitution. Okay. It's been done, it's cost effective, but it's also the right thing to do. So even Court of Law, we can do something different. All of these emotions can lead to isolation and loneliness, and those states are very, they put us at risk for acute and chronic stress to feel isolated. So I think you'd agree with me that, look, these reactions are normal. We wouldn't want to train a generation of clinicians who were like, nah, it's not my fault, things happen, hey, whatever. Well, actually, we suffer because we care, and that's appropriate. And many times we move through these acute traumas for us, and recover and learn. But sometimes recovery is thwarted, and this can cause significant harm. And I'm just going to really briefly show you some studies. There's many more. You may know of some more that shows some of the things. For example, with this stressor of error, of the things that can happen. And this looked at, depending on what kind of error, what were the effects on, and you can see very high percent of clinicians, or this was specifically a physician study, increased anxiety about future errors, decreased job confidence. We talked about that. Decreased job satisfaction, sleeplessness, harm to professional reputation, even in the blue lines when that error didn't even reach the patient. That's amazing. Like 1 in 10 people felt, they had a harm to professional reputation, even when they had a near miss. That's a lot. And then, 15% noticed that if there was serious error. So you can see that there's a lot of people suffering. We did a study looking at a hospital in the UK versus when I was at the Brigham, our hospital, nurses and physicians on both sides of the pond, no difference between the 4 groups, but almost a third had some negative impact on these domains. We know that burnout and depression are independent predictors of having made a recent major medical error, okay? And so there's this cycle, like if you've made an error, you have a higher chance of being burnt out. If you're burnt out, higher chance of making a medical error, okay? Very sadly, making an error increases, more than doubles the chance of suicidal ideation. That's really devastating. And it's probably true with completed suicide that we know, I think you may have heard of, but I can tell you, I know of examples of physicians who've died by suicide after errors because they just couldn't take the shame and all the other negative reactions. So we have to do something different. So we did a study several years ago where we looked at lots of different stressors, and this also happened to be this one happened to be a physician study. And we asked lots of questions about different stressors. The graph I'm going to show you was an answer to, if you were involved in a medical error, where would you want to get support from? And 88% wanted to be supported by a physician colleague. Even though we had great mental health professionals, EAP, employee assistance program, the vast majority wanted to be supported by a physician colleague. And another study looked at what were the things that correlated with resilience after adverse events, and resilience defined as what as actually growth through trauma. In this case, we called this wisdom, gaining wisdom instead of having it, really crush us. And one of the factors was talking about it with colleagues. So we decided we got to build a program that addresses what we know from studies. What do people want? And so it's this formal peer support. So what is that compared to the other kinds of support on a spectrum? One is informal. I bet everyone in this room, the virtual room together, has done informal peer support where you check in on a colleague after what could have been a stressful event, which is great. And for some people that'll be enough, but not for everybody. They aren't really expecting you to, hear them say, I'm falling apart, I can't sleep, I'm questioning my own competence. So for some people, they're going to need something more, and that would be formal peer support. Formal peer support, though, is not longitudinal care. It is not coaching or mentorship or therapy or anything like that. It is a peer, a colleague trained to provide, let's say, an hour-ish conversation with someone in acute, experiencing a stressor that the peer themselves, of course, has experienced, which is with errors, all of us pretty much. And so that may be enough for some people, but not for everybody. And some people need and want further professional resources like counseling. The problem is there's so many barriers to accepting or wanting or being able to get counseling that one of the jobs that when I train peer supporters to do is to destigmatize and facilitate referrals for further professional resources should the peer want them. Nobody gets pushed into any support of any kind. So that's where formal peer support sits within this spectrum. The principles of it, obviously, I train people to do this. and I believe you have to train us non-behavioral health practitioners, and you have to train behavioral health practitioners too, because this is different from therapy. I mean, the good thing about doing this as a surgeon is nobody thinks I'm actually a therapist, right? Like, no mistaking that I'm not. And so, these are the principles, which is giving your loving presence to your colleague in a setting that's psychologically safe, listening, of course, and validating, but also using non-judgmental curiosity to really dig down as deep as the person wants into what's bothering them and how to move forward. The idea is to help them get started on a plan for their own healing. We use reflective prompts to check in on sleeping, concentrating, suicidality, those sorts of things, and explore with them what are their own coping mechanisms, and encouraging their adaptive ones and discouraging any maladaptive coping mechanisms. And then helping them see, whatever the stressor is, that it's a part of what's happened to them and who they are, but it doesn't define them. And then, as I said, connecting them to resources and appreciating that they shared. The problem generally with support, and we wrote an opinion piece in the New England Journal, and my colleague Tim McDonald wanted to call it "If you build it, they won't come." But New England Journal doesn't think titles like that are funny. We didn't even try, actually. The point is that many places already have support, but it's not support that gets utilized by many healthcare practitioners. So just because you have support in place at an organization doesn't mean it's actually going to be utilized by the people who really need it. And so we talked about what are the principles that you need to do to actually build a program that can get people the support that they actually want. But for many reasons, cultural and personal, there's a barrier to getting. This was from that other study, where if you wanted support, what would get in the way, if you would, what are the barriers to seeking it? And you can see, no surprises. I don't have time to do it. I'm worried about confidentiality, stigma from getting support, and even, not being sure how to actually do it. So you have to build a program that helps people, these barriers be overcome. And I think these are some psychological barriers about, we have a culture of silence, which leads to isolation. People feel they're the only ones having these, awful feelings. Our needs don't matter. Self-care and self-compassion are selfish. I put that in yellow because I think we're taught that, right? And I think there's more understanding now that the burnout literature has, hammered this for us, but that if we don't care for ourselves and use self-compassion, the problem is, in the moment may be fine, but never processing some absolutely human emotions that we feel, given the things that we see in our careers, that's not sustainable. That's burnout material. So ideally, peer support programs are reach out, meaning they that you actually know of an event that could be stressful, whether it's patient aggression or adverse event or litigation, and someone is assigned as a peer supporter to reach out and offer support to somebody. And they can easily decline it, but you normalize it. Hey, a lot of us find it helpful to have support in these situations. Is that something you'd like to do? It's also important to have that's a reach out component, to have a reach in that's easy, like it's really quick. People know how to get the support if they want it. And I think, waiting till somebody's stressed and, really not functioning well is really wrong. Like, we can proactively say, this is a potentially stressful situation. Would you like support for it? And then I think integrating this, even if there's no formal peer support program, what if all of us as educators, what if in our daily lives, or certainly at times, acknowledge, wow, that was really tough, that patient death. That's someone we were close to, maybe in the ICU or something. Could we just take a moment here together to appreciate that, how hard this is, because we care. And then saying, there's lots of ways to get support, encouraging people if they need it or want it to get it. I do think that we have to show that vulnerability is courageous and not weak, right? We have to model it. Hey, we will say, this is stressful for me, or I had a similar situation several years ago, or when I was, a resident, and it really was hard. Here's some of the things that I did to move through it. But not say like, have this image of like nothing bothers me because I'm just so experienced and nothing negative happens. So as I said, lots of ways at times that I think we should reach out and provide support and make it easy for people to reach in. I think that peer support is a culture change tool, right? It can have us go from a culture, shame and blame to a just culture, a safety culture, where we say, no, actually, you did, you made the choice because you thought it was the right thing. I mean, there are very rare occasions where we do punish people, like if they, to be extreme, if they came in impaired, right? And, harmed a patient, obviously that's different, or they've made five of the same errors, like that's not shame and blame, but we would say, okay, there's a problem here, and it's not the system, it's maybe you need retraining or what have you. But most errors that we make are human error, defined by at the time it seemed reasonable for X, Y, or Z reasons. Turns out it wasn't. And we're going to say, no, we're not going to shame you. We're going to actually all learn together. It goes from saying, you made this error because you're a bad physician, to it happened because you're human. And these things do happen and they feel pretty awful. And we're going to work through them. This expectation that nothing should hurt, walk it off. There's no crying in surgery, for example. And it normalizes people feeling pretty devastated. It takes away from this sense of isolation, because a peer is connecting with you, saying, hey, I've been there. How can let's work together to help you start to strategize moving forward. And it really gets us away from self-care as selfish, which is something we talk about during peer support, which is, hey, you deserve to take care of yourself and to have people help take care of you, because you're important. You're really important. And, on a meta level, having your leaders organize a grand rounds, this or others that you do about well-being in particular, says like the leadership cares about you. We don't consider this a waste of time. We consider this essential because we care about you. And I think that's modeling this idea that, having you be able to do professional development or what have you is important, because your careers, matter, and we want them to be sustainable. I don't use the term second victim. As you know, was used a long time. Well, it used to be used. Some people still use it. I don't like it because, for one thing, this is from an educator named Parker Palmer. He talks about just general, this is nothing to do with errors, but that we're, that victimhood is sort of a passive stance, that we're co-creators of our world, which he sees as an awesome responsibility and a profound hope for change. And in addition, the patient advocates I work closely with do not like our referring to ourselves as second victims, any kind of victims, when we've inadvertently harmed them. What I want to do is, before I open this up, because I'm really curious about where this lands for you, and also open to talking about related or other things. I thought this tweet was so powerful to me. It really resonated for it wasn't written for this, but I dream of never being called resilient again in my life. I'm exhausted by strength. I want support. I want softness. I want ease. I want to be amongst kin, not patted on the back for how well I take a hit or for how many. Instead of hearing, you are one of the most resilient people I know, I want to hear, you are so loved. You are so cared for. You are genuinely covered. I just thought that is so beautiful. And I also want to say, I think resilience is a beautiful thing, but I will say that we need to take back the word, because I think it's come to mean to us in medicine, hey, it's on you. If you just did your deep breathing and you're training for a marathon and you're cooking your own healthy meals and meditating a couple times a day, well, by gosh, then you could just overcome these big stressors in your life. And that's not fair, right? Resilience is one aspect of well-being, and I'm all for resilience efforts, but it can't be, it's all on your shoulders. So I like the definition of resilience as being growth through adversity, and the responsibility of that being on individuals, on colleagues and even the organization to resource efforts to help us, right? And then also, this is a little bit of a side, but important issue. Organizations should stop doing things that are chronically causing us incredible stress. And there are things that organizations do that they should stop doing, that are undermining our well-being and that at the end of the day aren't even good for patient care, like too much production pressure, for example. I'm not saying your organization does this, but many do. And I think we've got to look long and hard about what organizations, their responsibility to stop things that are really undermining our well-being. So my point is, resilience isn't a bad thing. It just shouldn't just be on our own shoulders for this growth through adversity. So let me stop sharing, just figuratively, or I should say literally, not figuratively. And I'm going to pause, and I have a question for you, and in parallel, absolutely welcome questions from you or comments. So my question is, how does this land for you? Where does this sit with you? I see there's a lot in the chat, but that might have been from other things. So I'm gonna, Shari, are you gonna run this show? But I a lot of times, speakers say, okay, do you have any questions? Which is great. I love questions, but also like, I also want to hear, what about this, dear? Are you like, yes, this is awesome. What about it? It's like, I don't know, or have you thought of this, or we tried that, or I don't like that, or what have you. So yeah, you don't have to put it in the chat. You can unmute, and we'll have some good old organized chaos in the conversation, because I'm really interested in where this lands for you. And the last thing I want to say is, if there are any related things that, that you've been told that I have expertise in, some in the intro that you want to talk a little bit about, I'm happy to do that too. I'm really here for you. We wanted to, start off with this conversation about peer support. So here we go. Let's hear what you're thinking.
Thank you, Joe. What a fabulous conversation starter. This is, when you say, how does this land with you? A lot of the things that you've said today, I've heard expressed a lot throughout our faculty. And we have some comments that reflect that in the chat. So somebody says, you made the point that I was just going to make. Faculty / employee EAP is rarely used by physicians. And like it or not, I mean, EAP can be a wonderful resource, right? And it offers a lot of a great support potentially. But I think for some reason, for lots of different reasons, it's not used by physicians. I don't know if that's because they see it as punitive or too much connected to the organization or what. But do you have any comments about that?
Yeah, I do. I mean, I think, thank you for highlighting that. When we started the peer support program, when I was at the Brigham, I worked really closely with two women in particular from EAP. We had our in-house EAP, some places, outsources, but we even had our own in-house EAP. And we knew from our own, looking at our own utilization, and I had from talking to so many people at different organizations, physicians in particular don't access EAP. For certain things, like definitely for some things like childcare issues or, those sorts of things, all important. These are really important things for us to have resources for. But there's something, and, this obviously we found this in our study, very particular about certain stressors that we experience. And people, healthcare providers want to talk to other healthcare providers who know what it feels like. I mean, and I've done a lot of peer support, and so I always ask, like, who supports you, generally in your life. And, some people say like, well, my spouse is really supportive, but they don't really know how bad this feels because they're not in medicine. And it's nothing wrong with the spouse, right? It's just, this is some of these stressors, patient aggression, being reported to the board, making an error, those things, they're just very specifically horrific from, in a sort of, a specific way. And so I think that is the biggest reason, I think, for sure. There's other reason, which doesn't have to be there, but I think if it's not a fellow healthcare provider, sometimes people don't trust things that are set up within an organization as to be safe. But I think it's more just, people just say, I got to talk to someone who really has been there.
Thank you. That's wonderful. Dr. Lawler has his hand raised right now. Dan, do you want to go ahead and just unmute yourself?
Yeah, hey, thanks. Really appreciated the presentation, and I think a lot of this stuff does land. I'm an acute care surgeon, so a lot of this stuff lands very, very well. Your point about having, well-trained peer support is also very important. So yeah, I think that lands really well. And the other thing I just wanted to say was I think, you talk about resilience, the corollary to that for me is compliance, right? Is that you have to be compliant with so many things, and yet you're supposed to be resilient and compliant. And you're sort of like, those two things feel at odds frequently. So yeah, I just really appreciated it. Thanks.
Yeah, thank you, Dan. And I just want to pick up on both things. The last thing you said, I haven't heard anybody say it the way you did, but that sort of tension between if you're not compliant, that really just means you're not resilient, right? And I, like I could go on with you about this. It's like, actually, no, that's just wrong for you to be asking us to do that. Or I can do it, but here's the effect it's going to have on me and my colleagues. And I think resilience has been used sort of as a cudgel in that way. And I think, again, I don't think any administration or anybody walks in the hospital saying, I'd like to just beat down the healthcare providers on the team, but it's things that happen unwittingly. And unless we realize like, this is how this is feeling and give that feedback, it's just going to keep happening. So thank you for pointing that out. Yeah, I think you said two things within the first point. One is there's certain people who are going to be better at being peer supporters than others, period. They just are. And from my experience, and I don't have an RCT to back this up, but yeah, I think it has a lot of face validity. A good peer supporter is someone who is both a relational person, like just someone who is good at relating, and also you respect clinically. Like it's just those two things sort of have to be there. So the last thing that I know I talked about how do we make sure that happens is I think people need training, right? Because as a surgeon, personally, I go into everything wanting to fix it. Like with my kids, I did. I mean, it's like, and it can be so misguided. Like, no, yes, my patients, if they have Zankers, they want me to actually fix it. They don't want to just hear how hard it is for them to not be able to swallow. Like, I mean, I will hear that, but that's not why they came to me, as far as what I'm supposed to do. So when I do training, and I do, and I don't want to say like, this is the only way to do it, because I have a certain program. I've done it a certain way. It doesn't mean it's the only one. It isn't, right? But this is my way of thinking as an educator and as a clinician is you have to train clinicians out of the fixing, right? But it's more than just listening. And so that's why, I showed you like sort of a summary of what I do in training is I try to help people use these techniques of non-judgmental curiosity, but also reflective prompts, lots of ways that are going to feel to like a behavioral mental health person is really much more intensely like, well, what about this? What, invasive, if you will, than they would be comfortable with, which is fine because we're doing two different things. So I think training matters, again, that's my bias. I am the trainer, so I'm going to take it with a grain of salt, is that you got to get the right people in the room to do the training, and then you help them, train them out of their natural instinct. First, to some of it, their natural empathy, you want to keep that, of course. And the way we try to select peer supporters, and this came from trial and error, we used to do it with just self-nomination. But the thing is, some people who think they're going to be good at this just are not the people you'd want. So instead, when I help, I've helped lots, over 100 programs start, healthcare organizations start these programs. I suggest they get peer nominations. So that explains what the program is. So it's like a program awareness, and then they get to choose people who they would want to talk to as trained peer supporters, and then we train those people. So you put in a lot of points in your comments. I just wanted to pick up on them. Thank you so much.
Excellent responses. Thank you, Dr. Shapiro. Dr. Register had her hand up next.
Hey, my name is Anita Register, and I really appreciate this topic and what you're talking about. And I really love that quote you said too about resilience, because I think there's this just kind of general cultural thought that you're resilient if you hold things in, if you don't shed tears, if you're not vulnerable, if you take everything on and don't complain about it. And really, I think that culture definitely needs to change, and there needs to be more openness about things being hard and being okay to talk about that, being okay to cry about it, being okay to just be vulnerable and open about what you're going through. And I don't know if you've recently heard about the oncologist in New York City who they suspect had postpartum psychosis and was involved in a murder suicide with her 4-month-old, which is just absolutely heartbreaking and devastating, but definitely just kind of another topic on well-being. And yeah, and then with all the EAP stuff too, and just kind of getting support too, I think a lot of it is also just time. And like when you feel overwhelmed, it's hard to also find time to access some of that too.
Well, thanks, Anita, for sharing that. And I mean, that was so tragic. And yeah, I think that's exactly what apparently did happen. And we have, of course, a history in medicine of really not recognizing, providing support for any kind of mental illness or mental health, if you want to say it that way, which is so to ourselves, right? Which is so ironic. Like there's tremendous stigma. Just the fact that there's still, I think it's like 15 state boards that ask you for your licensure renewal and initial if you've ever sought help for mental illness. Well, it's none of their business. There's nothing they should be asking about that. And it has stopped people from getting mental health support. So, there's a good national conversation about this and trying to push those boards to stop doing that. And same thing with hospital credentials, none of their business. It literally is none of their business. So there are these structural barriers. There are these, stigma about, well, you're not supposed to, have these problems. And we've got to hit it, I would say, from every angle for sure. And I want to say also, when you just talked about that, the other negative, connotation around resilience, if you think about the definition of resilience, then there's several, but the one I like is growth through adversity. None of that pairs with holding things in. Like, how has that come to be thought of as resilient? And I like the way you said it, which is like, well, we need to say that actually feeling feelings and processing them is, developing resilience. It is growth through it, because you're not stuffing your feelings down, which may work in the moment, but it's not sustainable often. And so I think, saying like resilience, nothing wrong with the term. We just have to redefine it for people and say, this is what it means to be resilient. It can include processing your emotions, and feeling your feelings and getting help when you need it. That's part of resilience. And then the last thing I want to highlight, which is I think this issue of like actually getting, finding the time and the resources, personal, to get help when you're in crisis, or I call these, these situations, these stressors, traumatic, right, is a big barrier. And so the way I suggest people, do programs do peer support is there's this proactive reach out. So let's say, Anita, we knew there was an event that happened in your, what kind of physician are you?
OBGYN.
OBGYN, yeah.
Somebody would be assigned, and let's say I would email you and I'd say, touch base, in the subject. And I'd say, hi, Anita, I'm reaching out as a peer supporter. Give me a call when you have a chance. You would call me and I'd say, I don't know if you know this, but we have this peer support program, and we reach out to anybody. And after any kind of stressful event, like what happened a couple of days ago. And the reason we do is because I and every colleague I know has been in something similar. And sometimes it feels really good to talk to a colleague. Would you like to do that? That is, I call it like you're putting it on a platter for the person, instead of like, oh, there's some number. If you really figure out, you call. And no, it's like, would you like this? And you can say no, right? But even doing that is an intervention, because now know, well, it's there and the organization cares. They've actually resourced this. There's somebody who I could talk to. I think that's really important. But I do think I want to think more like, offline for myself about about the, mental health aspect of, of postpartum, because I think it's, it's a huge, obviously, it's just huge. And I just don't hear us talking about it much within this context. So I want to be able to reintegrate it. So thank you for just giving me, that's really, really helpful. Appreciate that.
Thank you. Dr. Music, you had your hand up next.
Hi, Dr. Shapiro. Thank you so much for a wonderful presentation, very comprehensive, with lots of resources. Really appreciate it. I just want to make a couple of quick comments. I think that, when you talk about support for people, particularly for physicians, I think where some organizations get off track is that they start with what they think physicians want or need, as opposed to trying to find out which services physicians are willing to use, and then making those things easier to access. And so, for example, in Virginia, the Medical Society of Virginia started a wonderful program a couple of years ago called Safe Haven, which includes some statutory protections for physicians who seek assistance through that in terms of confidentiality and so forth. And they worked with the Virginia Trial Lawyers Association to accomplish that. So it's no small feat what they did. So now there's some really important protections in place for physicians, and now it's been expanded to nurses as well as pharmacists, for folks who seek services and support, of which peer support is a major part of this Safe Haven program. There's statutory protections in addition to the services themselves. So we're getting ready to do a trial of this in one of our departmental service lines here to see if we can study the effectiveness of it in terms of, are people willing to use it? Has it made a difference, et cetera? So just a wonderful emphasis. I love our EAP colleagues, but there's lots and lots of evidence that physicians in particular will not seek out the services that they need from EAP. So rather than always hitting that one resource, I think we need to broaden our approach to this and say, what will physicians actually use? And then direct them to that. The other question that I really think is important is the resilience question. I'm not going to repeat others have said, but it's the canary in the coal mine argument, right? I mean, you can have the most healthy, robust canary that anybody ever produced, but if you put them in a coal mine, they're not going to last very long. And I think the cultural and organizational aspects of well-being are so critically important, and we have to move on from this notion that people can take care of burnout by being more resilient or being more this or being more that. So I really appreciate the way that you emphasize that. Thank you. And just, we're so happy you're here. Thank you.
Well, thank you. And that's great to hear about that program. That's wonderful. Sort of on the other side of that, I was doing a peer support refresher for some peer supporters in New York through their medical malpractice group called MPRO. They have had me train a cohort of physicians who are peer supporters. And one of them was telling me last night that when I was doing this refresher training for them, that New York state just passed a law that would make it, well, passed the law and then it was tried to be appealed, but the appeal was shot down, that is now going to make anything that is discussed in M&M not protected and not safe, which is like, what I was just saying is like, that is the dumbest law I've ever heard. I mean, I'm sure there's dumber, but that's the dumbest I've ever heard. It's like literally the worst thing you could do for safety is to shut down M&M. And so, yeah, I mean, we have to keep, my answer to that, to them was like, all right, look, we can decide then what we're going to do in response to that law. We can still talk about anything we want in M&M. We can say, we're just going to, we're going to still do the right thing. We're going to learn from it. And, what happens, happens, versus we're going to shut down because this is, it will put us at risk of being sued. It's like, we still have to have M&M and we still have to learn from these things morally. We have to do it. And that came up with peer support years ago was, well, in Massachusetts, peer support, and most states, but not all, is not actually technically protected. And we talked to our malinsurers, we talked to our defense attorneys, our risk managers, and we all decided we're going to do it anyway. We're going to do it anyway because it's the right thing to do. And the consequences, the risk of not doing it is huge. I showed you some data. The risk of doing it is very minor. I've never seen it come to pass to be a problem. And we're not going to take notes, et cetera. So there's a lot of reasons that actual risk is very, very tiny and more theoretical. So again, sometimes you can do the right thing anyway, even if it, it's not protected. But I love that that Virginia's doing that safe haven work. I think all those things are fantastic. Thank you for sharing that.
You. It looks like as if we have another hand raised, and Dr. Lawler posted in the chat that there's a great New York Times article about asking, do you want a hug? Do you want to be heard? Or do you want to be helped? And then Heather Lovely posted the link in there, so you can access it right away if you want to click on that link. Not sure who has their hand raised, but if you want to go ahead and unmute yourself, Annette.
Yeah, hi, this is Dr. Bulis at the VA. I think Dr. Music and I are thinking along the same train. I want to thank him for bringing up the safe haven, because my thoughts were exactly what he was talking about, and they were about the legal implications of having such conversations with a peer, as well as patient confidentiality. So I'm not sure we have that at the VA, but I'm glad to hear that is in Virginia. So thank you for that information. Appreciate it.
Yeah, it's great if we can get organizations to change their rules and regulations and make things easier for us. And at times that they can't or won't or don't, we can still say, we're going to do these things anyway. We're going to do them. We're going to make sure that they're accessible. We're going to make the risk really, really tiny because we know the risk of not doing it. So, but yeah, I'd love to hear organizations that are trying to do the right thing.
Last comment in the chat. It seems like we are really talking about formalizing catharsis, recreating the self-narrative about what happened and why at each step. Interestingly, much of this happens, especially at the resident level, informally, but often that isn't the physical space for which these discussions can be had safely, and instead concerns of privacy trump catharsis. Great comment. I also wanted to make a comment that any of the resources that were accessible, Heather went and put the links to them right in the chat, and we will include those on our website with this presentation and any other resources that Dr. Shapiro has to share. This has been a great conversation today. Thank you all for being so participative. And Dr. Shapiro, thank you so much for inviting that discussion and really facilitating a wonderful conversation about this tough topic.
My pleasure. Thank you all for your presence and also for all the work you do. Stay safe.
Thank you. Have a great afternoon, everybody.